I want to talk about some of the therapies that we had, traditional therapies, all right? You went to the doctor's office, you got some quick relief stuff, right? You got the short-acting beta, the receptor agonist, the SABAs. What else did we have at that point?
Well, typically your mild asthmatics are being prescribed short-acting beta agonists, and rescue medication, we call it. And then when they reach persistent, and I think in all levels of our guidelines in terms of the NHLBI, pediatrics and adults, inhaled corticosteroids are the preferred controller medication, although in the very young children, I believe montelukast has equal standing. And then as you get more severe, you'll add a long-acting beta agonist, and then there's a number of other medications available.
Well, tell me about, it was cromolyn was in there, right?
I don't even, you can hardly get cromolyn
But
anymore.
back then, cromolyn was a standard therapy.
And they had to take it 4 times a day to work.
Cromolyn was it worked well in a certain phenotype, and in fact, that phenotype kind of defined as a response to sodium cromolyn. It had to be used 4 times a day, really, to get good efficacy. And we had controller medications. Cromolyn, theophylline was a controller medication.
Which almost nobody
We're going
uses.
back to my era now. and
I remember theophylline.
Yeah, so
Yeah, I
theophylline
got
was
a
our
few
controller.
patients
And then
toxic in
inhaled
my
steroids came in. And inhaled steroids really were a boon to asthma control, because then we could control, instead of half the patients, we could control the vast majority of patients. And we thought if we went high enough on the doses of inhaled steroid, we would get better control. The fact was, that wasn't true at all. That once we got to medium to higher doses, there was a plateau, and going higher really didn't get us anything. And then we figured out how to add in long-acting beta agonists, so albuterols that were extended. Still, probably the best outcome you can look at, and certainly big systems like Kaiser and other big systems, Mayo, look at this, is kind of how much medication someone's using. Not only their adherence to controller medication like inhaled steroids or leukotriene antagonists, but how much of that albuterol or short-acting beta agonist they're using. And most of our patients don't give us an accurate information about that, and that's really important. But in the future, we're going to be able to digitally, we'll have all this information coming to us, so we're going to be able to tell a little bit better who's using too much control. And the other thing is those bursts of oral steroids, because oral steroids are cumulative. Over time, it's a cumulative adverse effect, whether it's cataracts and glaucoma, whether it's osteoporosis, whether it's increased risk for heart disease. There are so many potential long-term side effects of these frequent bursts of oral steroids that it really is incumbent on us to try and figure out ways that we can minimize those long-term effects.
How do you know when you've topped out on oral steroids?
What do you mean topped out?
In other words, that's it. They're not working anymore. They're doing more harm than good. How do you know that that's the end of the oral steroid pathway?
When they're in your office every week sick, calling every other night, and you are going to the hospital ER and getting hospitalized?
Sometimes it's really subtle, though. I mean, John will tell you, I know we've talked about it before, sometimes even I, who am really concerned about the side effects, lose track, because so many different people in the system are prescribing oral steroids. It's not just you. And remember, they're also on inhaled steroids, they're on topical steroids, they're on intranasal steroids. These patients have a big steroid burden. And one of the unmet needs of these patients is trying to decrease these exacerbations and get rid of some of that steroid burden.
Intriguingly, a lot of these patients that become steroid dependent are doing it because of nasal polyps simultaneously.
That's a good point.
So what's exciting is these biologics, which are doing research and so far have shown a nice signal of efficacy in nasal polyposis. This could be a real game changer for these people.
From a payer's perspective, what are the big challenges here? All these medications were out there, all of them were mixing and matching. Some of them worked, fell out of favor because you had better medications. At the end of the day, though, from a payer's perspective, what was important?
For the longest time, it's always been poor compliance, right? It's always been, initially, it's patients' inability to use the inhalers properly, Then it was poor compliance with these medications. It was the side effects of these medications. And it was also, let's be honest, they don't have symptoms every day, so they don't take their medications every day, which obviously defeats the purpose of a maintenance medication.
But they would always take their rescue meds, right? If they got sick, they would take something.
Well, the truth of the matter is, a lot of my patients, even though I know my nurse spent a lot of time educating them, they come and they pull out of their purse, or it's usually a woman who has a purse, and they have the inhaled steroid, and they say that, you know, it's not working or relieving, and then the other medication, they get confused the purposes of their medication.
There was a famous episode of House in which a patient said her inhaler wasn't working, and she sprayed it behind her ears.
But you know, as a payer, it's interesting you pointed this out. If you look at the data, what's the average number of inhaled steroids that people actually fill a year? If they should fill 12, it's 3.
Yeah.
Combination therapy, where they're even getting a positive reinforcement, is 4.12 to be exact.
It's not that much.
So it's not high. But what's really scary is, as Peter mentioned, what do they do when they're having an exacerbation? There's one study by Partridge shows that people dial up their short-acting beta agonists, but what do you think they do with their inhaled steroid? They actually diminish it. Okay. So that's really scary.
And the reason is as someone who has asthma, when you're taking your inhaled steroid, you don't get positive
Correct.
reinforcement. And in fact, when you get a cold or a virus, it actually burns a little bit. And so you get a kind of a negative reinforcement. Adherence, though, isn't as easy as, oh, I forgot my medication or I mixed up my medication. Isn't as easy as, oh, I'm not taking it correctly. It's usually not, oops, I forgot to take my medicine, or I'm not paying attention to taking it correctly. It's, I'm not going to take it. I don't need to take it. And a lot of other reasons. Adherence is not a simple matter of just reminding people to take their medication.
But it's no different than any other chronic disease.
This is
Whether
true.
it's
People didn't
hypertension,
take their
dyslipidemia,
Hypertension.
People didn't
diabetes.
take their hydrochlorothiazide.
That's right,
That's
but
right.
it's much worse. If you look at adherence patterns of all the chronic diseases, asthma with inhalers is the absolute worst.